Good evening, everyone. I'm Dr. Shannon Crowe. I'll be joined tonight by my partner, Dr. Bryan and our practice manager, Louise, as we dive into hormone optimization therapy. This is the first in a series of at least 3 educational webinars where we'll be able to answer some of the most common questions about hormone therapy. But tonight we're going to focus mostly on menopausal and perimenopausal hormones. So first, you'll see a fairly short pre-recorded video where we explain what hormone therapy is and why you should consider taking it and what our philosophy is. But please make sure to stay with us until the end, because that's when we'll be answering your questions live. And hopefully we'll be able to get into some of these topics in greater detail. And for those who are attending, one lucky attendee will win our menopause goodie bag, which is filled with all kinds of fun supplements, skincare, and more. So we can't wait to get started and can't wait to see you for the live portion in just a bit. When we talk about female hormones, we're usually referring to the female sex hormones. So estrogens, progesterone, and testosterone. Estrogen actually comes in a few forms during our lifetime: estradiol, estrone, estetrol, and estriol. But estradiol is the most active one in our reproductive years and the most therapeutic and healthiest to replace. It supports energy, mood, skin, bones, and brain. Then there's testosterone. Yes, women make it too. We actually make 3 times more in our lifetime than estrogen. It's produced by the ovaries and adrenal glands, and it's crucial for libido, focus, muscle tone, and that inner sense of drive and purpose. Now, progesterone helps balance estrogen. It supports sleep, mood, and protects the uterine lining. One lucky attendee will win our menopause goodie bag, which is filled with all kinds of fun supplements, skincare, and more. So we can't wait to get started and can't wait to see you for the live portion in just a bit. When we talk about female hormones, we're usually referring to the female sex hormones. So estrogens, progesterone, and testosterone. Estrogen actually comes in a few forms during our lifetime: estradiol, estrone, estetrol, and estriol. But estradiol is the most active one in our reproductive years and the most therapeutic and healthiest to replace. It supports energy, mood, skin, bones, and brain. Then there's testosterone. Yes, women make it too. We actually make 3 times more in our lifetime than estrogen. It's produced by the ovaries and adrenal glands, and it's crucial for libido, focus, muscle tone, and that inner sense of drive and purpose. Now, progesterone helps balance estrogen. It supports sleep, mood, and protects the uterine lining. All of these hormones decline as we age, but not at the same pace. Testosterone is the first to drop, often starting in our early 30s, and it continues to fall fairly rapidly. Then after the final menstrual period, which is the definition of menopause, estradiol and progesterone levels fall to nearly 0. But even before the final menstrual period, many women start noticing symptoms: bad hot flashes, fatigue, brain fog, low sex drive, mood changes, vaginal dryness, and just not feeling like yourself. But even if you don't have major symptoms, these hormonal changes still affect your bones, your heart, and your brain. So there's really 2 reasons to consider hormone therapy. The first is obviously symptom relief. We can usually eliminate most of these symptoms and get ladies feeling like themselves again. But just as important, replacing some of these hormones we lose can prevent chronic disease like osteoporosis and possibly cardiovascular disease and cognitive decline, which may be even more important.
Hi, I'm Dr. Bryan. When we say bioidentical hormones, we're talking about hormones that are chemically identical to the ones your body naturally makes, like estradiol, progesterone, and testosterone. That's very different from synthetic hormones, for example, Premarin, which is actually made from pregnant horse urine, or the hormones in birth control pills, or even injectable testosterone cypionate. Bioidentical hormones fit perfectly into the receptors, allowing your body to respond the way it was designed to, for optimal energy, mood, libido, and overall well-being. And using bioidentical hormones just makes sense. When it comes to hormone therapy, the delivery method really matters. We don't recommend oral estrogen or testosterone because when taken by mouth, they're metabolized in the liver, and that process increases clotting factors and can raise the risk of stroke and cardiovascular events. That leaves us with transdermal methods such as pellets, patches, sprays, and gels for estrogen. And for testosterone for women, there are no FDA-approved formulations, but most go to a pellet or a cream. In our clinic, we found that our patients who choose pellet therapy often do the best and ideally experience the biggest transformations. Pellets release hormones directly into the bloodstream, provide steady levels without the daily ups and downs. If we're using drugs that may be covered by insurance in our clinic, we pretty much only choose estrogen patches and gels. At our practice, every hormone journey starts with a thorough consultation. You'll complete a detailed symptom checklist and we'll discuss your concerns, medical history, and current health. Before starting hormone therapy, we require baseline labs, a pelvic ultrasound, a current mammogram, and updated well-woman exam. For pellet therapy, labs are repeated about 6 to 8 weeks after your first insertion and sometimes at the 3-month mark to check the trough level. If everything looks great, we usually only need labs once a year. Most patients return for pellets every 3 to 4 months, though some last up to 5 months. For patients using prescription estradiol and progesterone, we follow the same initial workup, then repeat labs and follow-up every 4 to 6 weeks until symptoms are manageable, and then follow-ups are every 6 months to ensure dosing stays optimized. And for those using compounded testosterone cream, because it's a 503A compound and testosterone is a controlled substance, we like to check absorption and safety every 3 months with labs and follow-up. Our goal is to personalize your plan, keep you feeling your best, and make sure everything we do is safe, effective, and evidence-based.
So let's talk about 503A and 503B compounding pharmacies and the difference between generic and brand name drugs, because these details really do matter for safety and consistency when we're talking about hormones. So first, a 503A pharmacy is your traditional compounding pharmacy. They prepare medications one prescription at a time, customized for a specific patient. They're regulated by state boards of pharmacy, but not really by the FDA. So there's less oversight on sterility, potency, and consistency. Now, a 503B pharmacy does operate under FDA regulation and must follow current good manufacturing practices. That's the same strict standard required of pharmaceutical manufacturers. In addition, every batch is sterile tested, potency verified, and inspected by the compounding pharmacy we use. So we can be assured that the doses are very precise. And here's another important point that most people don't know. Almost all prescription hormones your insurance will cover are generics. So while generics are designed to match the brand name version, they've done all the research, The FDA actually allows up to a 20% variation in bioequivalence, which is huge. So you may be getting 20% more or less depending on the drug and the brand you're using if it's a generic. Now, it is important for me to say that there is no testosterone products that are FDA approved for women in the United States, unfortunately. But we know it has benefits and we use it off label. However, it is approved in countries like Australia and UK. So for testosterone in our clinic, for all these reasons, we prefer pellets because they are 503B and we know those doses are precise and predictable. But we do understand that some women are not quite ready to do that. Maybe they don't want to feel like them best selves yet. So we do a little bit of testosterone creams. But for those, we're currently only using one compounding pharmacy at this time because we do trust their bioavailability and we do see it proven time and again in the lab values. As we wrap up this portion of the webinar, I was asked to share why you should choose us for your hormone optimization therapy. And first is experience. As many of you know, I'm Menopause Society certified practitioner. Dr. Blonder is a member of the Menopause Society. We actually just came back from their annual meeting, which reaffirmed most of what we were doing. But we've actually both been prescribing bioidentical hormones for over 25 years. And our focus has always been on doing this safely and responsibly. Next, we take each individual seriously. We carefully listen to and monitor each person with labs, mammograms, etc., but really do try to customize therapy for each individual because each individual is unique. Additionally, I want to assure you that all of our providers, including our amazing board-certified nurse practitioners, who we just love, follow the same evidence-based protocols. So you can be assured that no matter who you see, you're getting the same expert care. I often tell our nurse practitioners that they know more about hormones than most doctors, and that's actually true because this is truly what we do every day. And finally, while I'm thrilled that menopause is finally a hot topic, I'll admit some of what we see coming from inexperienced clinics, med spas, and telehealth companies can be pretty frightening. But I hope you know you can trust us for our experience and safety because we take it seriously and we value your health.
Hi everyone, my name is Louise. I'm the practice manager here at Sweetwater OB-GYN and Sugarland Hormones and Wellness. Wanted to thank you for attending another great virtual event. So much great information. We will have a fun giveaway for one lucky winner. It is our menopause survival bag. Lots of great goodies in here, so we hope you are our lucky winner. You will receive a text message at the end of this event, and we encourage you to go ahead and respond to that so we can get you scheduled for a consultation to see if you're a candidate for this great bioidentical hormone therapy. And following the event right now, the recorded event, we will have a live question and answer forum. So get ready with your wonderful questions. You can ask those live of both Dr. Crowe and Dr. Blonder. They're ready to receive those questions and answer anything that you have. And again, thank you for attending, and we really look forward to seeing you soon. Okay, thank you. Bye-bye.
Okay, you're live.
Oh, okay, I think Louise got cut off there a little bit.
That's okay.
Hi, everybody. Thanks for joining
Hi,
us
guys.
tonight. We're really happy to be here, and it's really exciting day for hormones. I'm not sure if you've heard, but the FDA yesterday announced that they are taking off the black box warning off of estrogen products for women, which is just thrilling and way long overdue because this is based on a study that came out in 2002 that scared physicians and patients alike. And unfortunately, many women have been deprived of hormones. We kind of call it the lost generation over the past 20 years. And unfortunately, this is one way that we're on our path to reversing this. Although Dr. Blonder and I have been prescribing hormones for 25 years, and really the data from that study hasn't changed too much.
But we're happy to see that and then that come out, and it's going to be hopefully implemented pretty soon. And then just the second part before we get into the question and answer, our company that does such a great job editing this, they asked us to have a patient give a testimonial because we all like to hear each other's story, and we did not have time to do that. So just after talking to Dr. Blonder and Louise, I thought I would give my own testimonial because clearly I'm a menopausal woman and have been through different types of treatment. And patients are always curious, like, what do I do for my hormones? And so to try and not prolong it too long, when I was in my mid-40s, I was on a continuous birth control pill, which means you don't stop to have a period. And as you know, like, that's a form of hormone replacement, right? It's a very strong form of hormone replacement.
Being used all over.
Yeah, so it's actually stronger than the hormones that the estrogens we use now, but it is synthetic. And so despite this fact, I, like a lot of people say, I just don't feel like myself. My hair was thinning. I would wake up at night drenched in sweat, just did not fatigue, just like you name it, like go down the checklist. I had all of them. And so it took me a while because I was, maybe 44 to check my labs. But when I checked it, I'm like, oh my gosh, I'm in menopause. And so, and I'm like, but I'm on a form of hormone replacement that's really strong. Why is this not working? And so then I switched to traditional like patches and gels and progesterone, which we prescribe today. And it just I did not get much relief. And then somewhere during this time period, we were having all these patients come to us who had done pellets, and we were, not first to jump on that bandwagon, but when we educated ourselves, more and more, I decided to do the pellets myself. And I'm telling you, like, it was life-changing. Like a week or two later, like really, it's like the colors in the world were brighter. The night sweats went away. It just felt like like a completely new person. And so, yes, I'm a pellet patient. I've done them for probably 8 years or so. Louise does
Me
pellets. Recently, I decided to take a break so I could relate to more of my patients that do patches and the testosterone cream. And that I was going to do a whole 3-month period, and it just did not go very well for me. My patches were falling off. I was still waking up with night sweats and hot flashes. I kept forgetting to put on the testosterone cream. It was messy, it was sticky. I didn't know if it was on my clothes more than it was on me. And so I could not even finish that 3-month period. So I just had Laura, our head nurse practitioner, repelleted me last week. I'm like, please, I just can't stand this. So for convenience alone, for me, it's been great. And I feel much better. And then cost-wise, I was like, well, because some people think that pellets are so expensive. When I did the cost analysis, for me, it actually was more expensive for me to do patches, a compounded cream, a vaginal estrogen, and a progesterone than to do the pellets. But that's just my story. It works for me, but we do all kinds of hormones for patients. But we've kind of simplified our protocol, as you see in the video, because fortunately we have so many patients who are doing hormones now. We just want to keep things across the board the same in our clinic, so that no matter if you see me or Bryan or Laura or Katie or any of the nurse practitioners, we're doing things the same way.
Let me stop, and I'm a living witness because I watched Shannon go through all this. She actually, stopped pellets. She went on to gels, and she tried patches and different things that were out there, and tried and checked her labs actually, and put the clinical labs with how she was feeling and seeing the differences. And there were great differences. And so that's why we try to uniform things. We do everything the same way here as far as all our nurse practitioners, all the providers here. And we try to use the same companies to make even our compounding creams and our compounding gels, so that we have a consistency across all the patients, so they get really good generalized focused care on what their individual symptoms are.
Wonderful. Well, our first question, which is probably the most common, is, does hormone replacement cause cancer? Great question.
Well, yeah. Well, Actually, well, it definitely decreases your risk of colon cancer, which is amazing. And if you're on progesterone, it decreases your risk of endometrial cancer. But obviously, what they're probably referring to is breast cancer, which is always everyone's concern. But fortunately, like we just started out the presentation, the FDA actually is taking off that black box warning to eliminate that risk of breast cancer for estrogen products. But, just to kind of step back and look at the big picture, 1 in 8 women get breast cancer. So it's super common. So, and then if you look at the estrogen doses that we are giving people, they're way less than what you made before you went to menopause. So before menopause, your estradiol it peaks at like 400 or 500 a month. And what we're just trying to give you after menopause or perimenopause is like somewhere 30 to 80. So not even, high levels at all. So that's one reason we've kind of gotten away from the term hormone replacement, because we're just giving you some so you feel better and to help prevent some long-term problems. And then, breast cancer is multifactorial. So if you have a genetic, risk factor, if you have a modifiable risk factor, which everybody should be working on, which is, losing weight, exercise, healthy diet, eliminating smoking and alcohol, those are things that you can control with breast cancer. And then, I think the thing that people get hung up on is that a lot of breast cancers have estrogen receptors. Estrogen receptors are in our body everywhere, in our brain, our bone, our heart, our lung, our vagina, like everywhere. It just happens that breast cancers respond to estrogen deprivation, which is actually pretty unfortunate for all these breast cancer patients that have been told they can never take estrogen again. And so it's really my hope one day that they will be able to develop treatments for breast cancer that do not involve depriving you of all of your hormones, because those talk about a lost generation. Those women really struggle. But we do see a lot of breast cancer patients and have some alternative treatments for them so they don't feel completely miserable.
Let me add a little something. We're very strict here at Sugarland Hormones and Wellness and Sweetwater OB-GYN. We have strict protocols in place. So we require every woman to have her mammogram once a year. No mammogram, no hormones. We're very strict on that because it's protective against all the patients that we have. We want to, do the best we can do for you. Anyone predisposed to genetic breast cancers and genetic cancers, we are very aggressive as far as testing them in the office and going over their lab results and looking at their modified risk and the big picture before we do prescribe hormones. So we try to do that as a clinic. We try to be different than the rest of the clinics out there that are just giving out hormones.
Well, because your health is important. And, like we said, at least 1 in 8 of us will get breast cancer as women. And so if we can pick it up early, it's 100% curable. So that's why we're really strict. And even now with women with dense breasts, we're kind of recommending that you come in twice a year for a breast exam and do additional screening, which, reach out to us if you have questions about that.
There's kind of a follow-up question to that. It says, I've heard that some people have a marker that prevents them from taking estrogen. How do you know if you have that marker? Do you know what that is?
I don't know what they're talking
Oh,
about.
okay. Maybe like the BRCA?
No, that's not.
No, that's not a marker.
No.
No. Okay.
And people with, known breast cancers, they have, markers that they follow, but those are women with actually known breast cancers.
If you have a genetic risk factor, that's separate. That's, that's because of your DNA. It doesn't mean, even those women, like if they get a mastectomy, the ones that are, have like 80% chance of getting breast cancer in their lifetime, they can still take hormones. So that's absolutely been proven.
We give
But I'm
people
just
lots
not
of
sure.
avenues to
I'm not sure what
actually
they're
go
referring
get
to.
treated and all.
Can you still take birth control when you're on bioidentical hormones?
Yes. So perimenopause can be, a little tricky because your estrogen, we call it a roller coaster. Sometimes it's super high, sometimes it's low, sometimes it's really, really high. And so, those women, when it's low, they feel bad, but when it's high, they maybe feel worse. So what birth control pills can do during the perimenopause period, it basically flattens your hormones. So it gives you a daily dose of estrogen and it flattens at a brain level so you're not all over the place. And so for some women that actually is helpful, but those women can still do testosterone but not usually, progesterone. They can definitely do vaginal estrogen, That's something that's very common in perimenopause, to start having symptoms of what we call genitourinary syndrome of menopause, but basically just thinning of the lining of the vagina that usually precedes menopause. And so we can see it on exam. You may feel it as vaginal dryness or pain during intercourse, but those women can definitely do bioidentical estradiol prior to going through full menopause.
And we're actually treating the area that's affected. So we're treating this with local bioidentical hormones right to the area where you need it.
Next question is, how are the hormones administered? So I imagine she's talking about pellets, the question. How does the procedure go?
Pellet procedures are a fairly simple procedure. We numb the skin exactly where we're going to put the pellets, and we make a small incision, just enough to get a small trocar through, kind of like a piece of grain of rice is what they look like. And the whole procedure itself takes about 30, 45 seconds. We've been doing this quite a long time, very experienced. And women do very well. We give them instructions on how to take care of it, as far as 3 days of no hot tubs, no ocean, not going in the ocean, not going in the pool. And people do very well. It lasts for 3 to 4 months, but can last actually a little bit longer for women. And for men, we do treat men here. And for men, it lasts 5 to 6 months, and men do very well with it as well.
Yeah, the guys are easy. They usually just come in twice a year.
Yeah.
And they don't have to do a mammogram.
How long before you see an increase in libido trying the creams first, for example?
Well, I mean, every person is individual. So some people don't see anything on the creams. Some people see something maybe as soon as 2 or 3 weeks. We can go to different doses on the cream. So what we generally do is, we'll send a 3-month supply. We'll check your labs, see how you're feeling, and we can, as long as we can increase the dose safely, we can do that later. Libido in women is multifactorial. So yes, there's a testosterone component. We call testosterone the hormone of desire. And we know that goes down even starting in the 30s. And so that's a big component of libido, but for women, that's not the only component. There's relationship issues, there's stress, there's other medications, there's diet. So it's not quite as easy for all ladies, but we have some other tricks in our bag too.
Is it different for the pellets as far as libido?
Again, I mean, it can be variable, but like if you're doing a pellet, it's not uncommon, especially if you've never done it before, like week 2, we hello, I need to call my husband. Like I had a patient, she was in a grocery store and she's like, oh my gosh, my pellets kicked in. I called my husband, I left my groceries there. But that's not for everybody, so for some people, it takes a couple cycles before you see a full benefit.
I think you get better, a much quicker response with something that's going under your skin directly into your bloodstream than using a cream daily. With the cream, might take a little bit longer just to titrate the dose that works for you. And it might take several months. And I explain that to all my patients that I see. And if they're willing to work with that, we kind of go that direction.
So there are a couple of questions that kind of link together. So one is, I've been considering hormone therapy, currently 46 years old, postmenopause, and have been worried about my age starting this. How many years would you recommend somebody to do this type of therapy? And then the other question to that is it possible to eventually stop the BHRT, or is this something that continues forever? So maybe
I think there's a lot of.
Did you say 46 or 64?
46.
Oh, 46 is not too old.
Yeah, it's not at all. And there's a lot of, you have to remember, there's a lot of underlying benefits from hormone therapy that is valuable for long-term use. We might titrate the dose down a little bit and maybe spread the doses out a little bit but you still get the benefits of possibly helping brain health and heart health, and definitely bone health from both estrogen and testosterone. What you want to add to that?
Yeah, I mean, that especially like if she was, I was saying that maybe she's 64. It's not as clear, how long you should take hormones and whether you should start when you're, 75, just because there's not a lot of data on that. But there are definitely, besides feeling good, the long-term benefits as far as, even if you talk about osteoporosis alone, is huge. Osteoporosis is like a passion of mine. 1 in 2 women will fracture after the age of 50. If you fracture your hip, you have a 30% chance of dying and 60% chance of never walking normally again. And all that can be prevented by hormone replacement. So yes, we want you to feel well, but it's also about this long-term prevention. Part of that FDA black box warning is that they are saying that the best benefits for hormones are within 10 years of menopause or under the age of 60. That's kind of been poo-pooed a little bit by mainstream, like even the Menopause Society. It's just like there's not a ton of data on women initiating hormones later in life and staying on them forever. Personally, I will stay on hormones, probably until I die, unless I had an estrogen-dependent breast cancer. So that's when shared decision making comes in, where we talk to you individually. We don't treat everyone the same. So if you have major cardiac risk, maybe we would decrease your dose, or maybe say, well, let's just stick with a vaginal estrogen. You're not having symptoms. Your bones are great. So that's why we treat everyone individually.
There's a lot of talk right now all over the U.S. and social media about anti-aging, and anti-aging is becoming a very big topic in this world. And we want to do things that prevent disease and make your longevity in your life much more beneficial and happier without having some of these risk factors underlying.
There's a question, and you've covered some of it, I guess, already, but are there any health risks to BHRT? I know there's been a lot of medical advancements. However, my mother had breast cancer that was linked to her taking HRT after her hysterectomy in her 30s, and it makes me anxious.
Well, I don't know if you heard that first part of the conversation.
That's a great question.
Well, that's what we just kind of covered that. So just because your breast cancer has an estrogen positive receptor does not mean estrogen caused the breast cancer, especially if you're 30, we know that women who have hysterectomies at a young age have like a 2 to 3 times mortality from cardiovascular disease if they don't do hormones. So again, just because there's an estrogen receptor on the breast cancer, it does not mean that estrogen caused the breast cancer. And that is why the FDA is taking that black box warning off of the hormone. So it's just kind of hard to wrap your brain around. Your bones have estrogen receptors, but they're not if you have bone cancer, doesn't mean hormones caused your bone cancer. It's just that is the only way we know how to treat breast cancer right now.
Does HRT stave off dementia, osteoporosis, and heart disease? You've touched on some of it, but maybe not
definitely,
the dementia portion.
Definitely osteoporosis, for sure. If you're talking about what we see in the clinic and versus data, we cannot clearly say based on data that it prevents dementia, but we'll tell you every day that women think clearer on hormones. And we believe it. And it's just because there's not great data that shows it eliminates dementia. Most of that data is pretty neutral because there's just not a ton of studies in women in general. Cardiovascular disease, like I just mentioned, we know, especially based on women who've had a hysterectomy at a really young age, they're at super high risk for cardiovascular events and cardiovascular disease. And we do know that hormones stop that. So that's why it's kind of been put forward that women in menopause, when we know all these cardiovascular things start happening, that the hormones have to help. And there are tons of studies that have shown that. One is called the ELITE trial, and it showed women actually on higher doses at the time of menopause had less thickening of their carotid intima media, which is like the thickness of the blood vessel. And so it's been extrapolated that it does prevent cardiovascular disease.
And women tell me all the time when they start their hormones that their brain fog has gotten well improved since starting their hormones. So we really believe underlying that there is definitely a link to brain fog and obviously the cardiovascular disease. And like I said, it's an anti-aging thing. I think we're going to sign on to something that's going to give us longevity, a good quality of life, and better healthy life. We really believe that here at Sweetwater OB Gyn, Sugarland Hormones and Wellness. Any
news on when the FDA will approve testosterone for women?
I think it's probably a long time coming. It's clearly been shown that women have benefits. There was a patch, I don't know called Intrensa that the Procter & Gamble spent millions and millions of dollars on. It's testosterone patch for women. It's shown to be very effective for hypoactive sexual desire disorder. But there was literally one person in the FDA who would not put it forward. And this has been well over 20 years ago. So they just said, well, we spent too much money. We're not putting any more research in it. And that is as far as testosterone has gone for women.
Wow.
But just with this black box warning going away, I am hopeful that women like you and doctors like us are pushing that message forward that testosterone is safe. Women make a ton of testosterone, much more in our lifetime than estrogen, and it does have benefits. And it's FDA approved, or their version of FDA in multiple other countries, and has been shown to be safe and effective.
How does this work with women who've had blood clots in the past?
Well,
Yeah.
Blood clotting too is multifactorial. There's lots of underlying reasons that can cause blood clots. Like, the hormones we use are all bioidentical. It's a plant-based molecule that kind of fits into your body's molecule that you've produced all your life. And so we feel that is a safer method. If someone has a blood clotting issue, we always send them back to their initial doctors that diagnose their blood clots, make sure that they're safe to take hormones, find out what the blood clot was caused by, and any other multifactorial things that they have that can cause an increased risk of it. We certainly screen people well before we start them on hormones.
Yeah, and so the big concern with blood clots are the oral estrogen, so like birth control pills and oral testosterone, and that's one reason in our clinic we don't even rarely would do an oral estradiol. And the reason is, those orals get metabolized in the liver in what we call the first pass, and that increases the clotting factors. And so all the studies that have come out on transdermals and pellets have not shown an increase in clotting. But, it depends on why you had the clot, other risk factors, your genetic. Again, that's going to be a more careful discussion with us.
Should a woman reach menopause before she starts BHRT, or do some women start during perimenopause?
Well, we kind of covered that, but you can definitely do vaginal estrogens, definitely testosterone if you're a candidate for it. We're a little slow on starting estradiol too early, just because it can really, you shoot your estrogen up too high, cause irregular bleeding, cause endometrial cancer even. But again, that's kind of a one-on-one discussion. But definitely progesterone, testosterone, and vaginal estrogen in perimenopause, 100%.
Yeah, everybody's individualized here. We go case by case, woman by woman, man by man, because we treat men as well for testosterone.
Yeah,
and we individualize everybody's care based upon their symptoms, their labs, where they're at in their life, and we try to, make things as clinically correlated to what's going on, as well as their safety.
How difficult is it to switch from the estradiol patch to the pellets? So you kind of talked about your experience.
Yeah, not at all.
I guess.
It's very easy, and vice versa. We have patients that go back and forth because it's fine. We see patients for life, so sometimes they'll want to try the patches, just make sure they feel okay. Not sure if they're feeling great enough, or if they feel better on pellets, they switch. They go back and forth. It's fine. We know how to dose people on different formulations. So
It's very easy to do as well.
Yeah, our patients are our patients for life, so we listen to them and try to adapt.
Question, can you do a daily injection instead of the pellets?
No. I mean, not in our clinic, and I would not recommend it.
Yeah.
There's an old injectable estrogen, Del estrogen, that some old timers used to use back in the 90s, 80s, and 70s, but I don't know why all of a sudden that became popular again. And then we don't use, you can do injectable testosterone. We don't recommend it because it's a synthetic. It's testosterone cypionate or enanthanate. So we do not recommend it or do it in our clinic, at least at this time.
And does the pellet procedure leave a scar?
It depends on the person, but
Everybody's scar is different.
Yeah.
But it's a tiny 3 millimeter little bleb that you would see. And when we bring people back, we usually alternate sides, and We usually go into the same exact area where they're all going, so they don't have a bunch of little
If
marks.
they even see it,
Most
some-
people
yeah,
don't
you
even
can't see
have,
it, yeah.
most people, it's really hard to see. It depends on their skin blemishes and pigmentation and whatnot.
And if you're like, I have some people that, like wear thong bikinis, so kind of hide it in that little thong
Yeah,
line.
we're
So
very
yeah,
aware of
so
that.
we're aware of that. But for the most part, most people aren't looking at their butts every day. Maybe their partner is, but you usually don't see the scar if it even scars.
Yeah. Are there any labs that tell that you're in perimenopause?
Yes and no. Definitely we see a drop in the testosterone, and perimenopause is based more on your symptoms and your age. We'll see usually the periods either space out or have the period changes is actually one of the hallmarks of perimenopause. Estradiol levels can fluctuate. So again, like we said, I can see people, their estradiol is like through the roof some days and super low on other days when they're in perimenopause.
And, we don't treat labs because, perimenopause is very difficult to define. We treat everybody's individual symptoms, where their labs are, we follow them, and we trial things that we think will relieve their symptoms that are safe.
Can I start HRT if I have the MTHFR gene mutation?
Yeah, for the most part, that's a very small, it's more a risk factor for not absorbing folic acid. If you're homozygote, again, there's a different mutation. So if if you have two copies of one gene, we may start you on a transdermal that we could reverse immediately because there is potentially a small increased risk of clotting. But for the most part, again, these transdermals do not increase the risk of blood clots. Now, it is important, like about 60% of Americans, have the MTHFR mutation.
Yeah, very common.
And so what that means is that you cannot absorb normal folic acid. So it's really important to take methylated B vitamins and folic acid. And so that's also, we have a bunch of supplements that we recommend and customize to people, but a huge one that is made by BioIDentical and actually by Thorne is called methyl factors. And I love it because most people do have this mutation and they may have fatigue that is not caused by hormones. It's caused by these methylation factors, but that has methylated folic acid and B vitamins. And so it definitely helps with energy and also with the brain fog.
Very cool. Well, we actually have a wonderful comment on here from an existing patient, and she says, not a question, but I've been a patient with you and had wonderful results. I'm able to sleep at night, build muscle, feel more energetic, and libido is wonderful. I've done both the pellets and cream, and both have worked amazing. So that's a wonderful online testimony. Thank you for that. You know who you are. And I guess we're kind of close to wrapping up. So at the end of this, you'll receive a text message asking you if you want to get a call to maybe schedule, or if you have more questions. You can text the word sugar back, SUGAR, just as sweet as we are. And then we'll get in contact with you. And then also, if you're an existing patient and you use the patient portal, you can even send us questions there. You can request appointments there. So feel free to do that. And remember to stay tuned because we have more of these coming.
Yeah. Oh, yeah. And so, to follow up on that, we'll be doing these every other month for a while. So if there's certain topics you think you'd like us to cover in more details about hormones or menopause and perimenopause. Yeah. Well, more hormones, but weight loss, we didn't even get into weight loss. That's a whole other topic, but hormones help a little bit, but there's a lot of other things that can help because women do gain weight in menopause and it's really frustrating.
Wonderful. Well, we thank you so much for joining us.
Thank you
Thank you
guys.
very much. See you soon.